Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. I'm Andrea Bianchi and I'll be the moderator for today's session. Our speakers are Dali Menedak, Aman Siam, Kara Sodomo, and their seminar is entitled Balancing Family Presence in a Pediatric Hospital During the COVID-19 Pandemic. Before I introduce today's speakers, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics website. The format of our seminar is a presentation by our speakers, followed by a facilitated discussion period. We would like to take a moment to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. We also stand in solidarity with the ongoing protests against racism and systemic discrimination. Now, it is my pleasure to introduce today's speakers. Dali Menedak is the clinical bioethicist at Holland Bloorview Kids Rehabilitation Hospital, vice chair of the Research Ethics Board, and the Youth Engagement Strategy lead. She is particularly interested in pediatric rehabilitation issues that arise in both clinical care and research with children and youth with chronic illness and disabilities. Dali has over 10 years of experience on pediatric research ethics boards, both at acute and rehabilitation hospitals. Dali is the alternate ethics member of the Ontario Cancer Research Ethics Board. Dali is a nationally and internationally sought after leader in lived experience roles and has been the youth engagement strategy lead at Holland Bloorview since its inception in 2012. Dali has extensive experience training and supporting youth and young adults in advocacy and partnering in the areas of service and care delivery, teaching and education of healthcare providers, clients and families, as well as research and policy. Aman Siam is the Director of Client and Family Integrated Care at Holland Bloorview Rehabilitation Hospital. Aman and his team partner with the hospital's community of children, youth, and families to design meaningful programs and services, research and policy, and direct care experiences. He holds an interest and expertise in the intersections of client and family-centered care, health equity, and human-centered service design. Aman is a doctoral candidate in the Department of Social Justice Education at the University of Toronto, Ontario Institute for Studies in Education. Kara Sodomo is the infection control lead at Holland Bloorview Kids Rehab Hospital in Toronto, Ontario. A registered nurse with over 40 years of experience, Kara has been at Holland Bloorview for the past 35 years with roles that include being a staff nurse on the inpatient rehab unit, an RN for the day patient program, risk manager, and infection control practitioner. Over 20 years as an infection control practitioner at Holland Bloorview, Kara has been a strong advocate for several patient safety initiatives. She has developed, communicated, and implemented key strategies that have improved infection control and patient safety practices at Holland Bloorview. Kara is a member of Toronto Practitioners in Infection Control and the Paediatric and Neonatal Interest Group of IPAC Canada. She has her certification in infection control and a master's of public health from the University of Waterloo. Now it's my pleasure to hand it over to our presenters.
Thank you, Andrea. I am going to share my screen in order to pull up these slides, and I'm hoping that you can see those slides. Andrea, I'll just look for you to give me the nod. Yes, fabulous. So thank you so much, all of you that are joining us today. Thank you to Andrea for that wonderful introduction. Kara, Aman, and I are looking forward to sharing our experiences of balancing family presence in hospital during the pandemic with infection prevention and other considerations. During a pandemic or public health crisis, difficult decisions may need to be made about access to care, mobilization, and reallocation of resources. Also, conversations about redeployment of employees and other measures that can help contain the spread of disease must happen. The decisions ought to be open, transparent, reasonable, inclusive, responsive, and accountable. And while this can be hard to do in times of crisis, it's more important than ever to make our decisions and their reasons known to our stakeholders and to the public. Many institutions, like ours, have a pandemic plan, a living document that acts both as guidance and a record of the lessons that we have learned after each time it's been necessary to use. We know that trust is an essential ingredient in working relationships when so much is unknown. The COVID-19 pandemic has created many unknowns, and we've all faced these challenges head on. Today, we plan to highlight how trust can be fostered when decisions regarding family presence in hospital during a pandemic are consistent, proportional, and evidence-based. Before we start on our content of today's presentation, Kara would like to give you an overview of what you can expect.
Thanks, Dolly. So this is what we hope to cover in our next hour with you. We're going to introduce ourselves, although you've had a nice introduction already by Andrea. We're going to give you a glimpse into our beautiful facility, a little bit of background on some pre-COVID caregiver presence policies, some context and considerations during COVID-19, and then also walk you through a couple of case studies that we have and some examples of some situations that we found ourselves grappling with, and then hopefully have some time for questions. So I'm not going to go over this slide too much because Andrea covered it well in the introduction. So just to highlight that I am been a certified infection control practitioner now for about 20 years. I do sit on these two wonderful committees, IPAC GTA, as well as a member of the Paediatric Neonatal Interest Group of IPAC Canada. And I did complete my master's in public health last July during this COVID pandemic, which was a feat in itself.
Hi, and good afternoon, everyone. It's great to be with you again, because I think our bios were read. I might just draw your attention to two things. In addition to my role, I kind of have this dual position at Holland Bloorview as co-chair of our Inclusion, Diversity, Equity, and Accessibility Task Force. So certainly a lens and collection of thinking that we've applied to the topic that we're going to speak to today. And I think equally as important, and I should add this to my bio, unrelenting Raptors fan. So go Raptors, go. And I'll hand things over to Dolly.
Thank you, Aman. And I like to capture everyone's attention with this slide because there's a great picture of my cat Rexy on here. I am a cat fan, although allergic to cats, I still push through and enjoy her company. Other than that, I think that the introductions by Andrea were really wonderful. And I'll just say that working with Kara and Aman on this presentation, as well as the Family Caregiver Presence Policy over the last 10 months, has been a wonderful opportunity and really grounded in our context of Holland Bloorview. Before we get started, we would like to ask all of you to take a moment, if possible, if you're logged into the YouTube and you have access to the chat, if you could give us a sense about the audience today. Here are some non-exhaustive examples of roles that you might be coming from, perspectives you might have. So we'll take a second and we're going to pause. And our moderator, Andrea, is going to be able to give us just a quick summary of what it is that our audience is telling us about themselves. I'll just wait for 1 second. I feel like our classroom photo here is representative of days gone by, but we can imagine our virtual hands instead. So I'll just ask if we are seeing any answers.
I'm just waiting for them to pop up on my screen here, and then I will read them out. Okay, so there's a registered nurse at multiple pediatric hospitals, an undergrad student studying philosophy, an RN, a research assistant, and a graduate student. Okay, they're still coming in.
Okay, and I think that helps us to start to get a sense, and maybe we'll check back with you, Andrea, throughout, and we'll keep going. And really, we appreciate you taking the time to let us know about you. So I'll pass it back over to Aman.
Thank you, Dolly. Before handing things back to Dolly and Kara to go deeper around our Family Caregiver Presence Policy, I'm going to set this up a little bit and give you a bit of context around who we are as a community and who we serve at Holland Bloorview. So you see a shot of our building there. Established in 1899, Holland Bloorview provides tertiary care for children and youth from birth to their 19th birthday, living with disability, medical complexity, illness, and injury. We're an academic teaching hospital. We are fully affiliated with the University of Toronto and Canada's largest children's rehabilitation hospital. We provide a diversity of services that includes physical and cognitive rehabilitation, as well as life skills programs such as employment readiness, transitioning to adult services, and programming in music, arts, science, and technology. Next slide, please. Great, thank you, Dolly. So this is who we are, again, at a snapshot in who we serve. We serve 8,700 clients per year. So if we break that down, that looks like 55,000 outpatient visits, 450 inpatient admissions. Our inpatient bed capacity is 75, and that's spread across 3 units, including our brain injury unit, our specialized orthopedic developmental rehabilitation unit, and our complex continuing care and respiratory unit. We care for over 2,000 diagnoses, so quite a bit of diversity in our clientele. And 70% of our population lives with more than one diagnosis. So on the inpatient side, the most common diagnosis is acquired brain injury. And on the outpatient side, it's autism spectrum disorder. Finally, about a quarter of our clients come from Toronto, and 60% come from regions immediately surrounding the Toronto area, most specifically Mississauga and Haliburton. Next slide, please. Thank you. So at Holland Bloorview, we have a long, I'd also say proud history of partnership with clients and families. Our Family Advisory Committee can be dated back to the 1980s, and our Youth Advisory Council just celebrated its 24th year. Youth and family partnership at the hospital ranges from and really cuts across spheres of governance to policy and research to service model redesign and co-design, right down to shaping direct care experiences. Our family leadership program and our youth engagement strategy, they'll offer informal ways for people to participate. Also offer formalized engagement structures and roles that invite our youth and family leaders. You're going to hear that phrase or term a lot, youth and family leaders. We're referring to lived experience volunteers when we say that. Offering them opportunities to act as teachers and facilitators, mentors and advisors, not just at our hospital, but also across the health system and beyond. Prior to COVID-19, we had been experimenting with virtual means of engagement for both family and youth leaders. And needless to say, and as the environment changed, so did our programming. So we very quickly went fully virtual, and both the Family Leadership Program and the Youth Engagement Strategy established rapid response engagement so that the voices and lived experience expertise of our partners was not lost and actually infused into the hospital's approach to pandemic planning and response. Next slide. Thank you. So I'm going to briefly touch on some, and this is definitely not exhaustive, so certainly not all, but some of the ways that the pandemic dramatically shifted client and family experience. And this is very much reported from families themselves. With the onset of pandemic, our families began reporting shifts that we've grouped into 3 major buckets here. So the first is abrupt and increased client isolation. So I mentioned we have 3 inpatient units. The average length of stay for our inpatient clients is 39 days, but actually for the majority of inpatient clients, it's usually a couple months, so it could be longer than that. And they were experiencing increased isolation, partly because of new restrictions on caregiver presence at the bedside and in the hospital, so less loved ones around due to provincial direction. Also because there's less peers around. So in acute cares, we saw the cancellation and also delay of surgeries. It ended up in less children and youth being transferred to our setting for rehabilitation. So less peers around, less loved ones around, and families and clients were expressing that really started to add stress and strain to the mental health of our clients, in some cases actually manifesting physically and compromising their rehabilitative journey. The second bucket is around family fears and uncertainty associated with discharge planning and home care coordination. So families started asking and posing new questions to us around what does it mean to be transitioned home in the middle of a pandemic? how safe am I to embrace home care clinicians to come into my home to deliver vital care to my loved one? And does that mean that I have increased risk for transmission of COVID-19? And then finally, a recognition that many of our families were already living in crises. So the pandemic compounded these already existing crises around the social determinants of health and the financial impacts of living with childhood disability in new and more exacerbated ways, whether it was food and housing insecurity, a lack of job protection and precarious employment, possibly a lack of access to the funding for critical medical equipment and PPE. So these are some of the things that began to really get surfaced with the onset of pandemic. And I'll hand things over to Kara.
Thanks, Aman. So just to kind of give you a setup of where we're coming from. So oddly enough, prior to the announcement of the global pandemic, we had just reviewed our pandemic plan, and we were in the process of completing our respiratory fit testing for our employees. We do this every 2 years, and we use our pandemic stockpile to carry this out. And then once we complete our fit testing, we would then replenish our stockpile. So after the announcement of the pandemic on March 11th, we pulled together a pandemic steering committee. We reviewed all the guidance documents that came out from the ministry, the memos, the directives, and everything. And then we looked at that to determine what we needed to focus on immediately, and then also looked at how relevant they were for Holland Bloorview. We started hearing reports within our facility around masks and disinfectant disappearing. So we had to pull them in and centralize them into our stores department. And doing this, we were able to take inventory of all our supplies and PPE. So because we had just finished our fit testing, we were now low on N95 respirators. And then we found out that this was a global problem, and allocation to hospitals were in very short supply. So we needed to strategize right away on how we could conserve our PPE. There were also some challenges that we heard around some medication shortages. So our pharmacy team took the lead, and they started stocking up on some items and medications that might be difficult for some of our unique clients to get access to. So we have some of our clients are on special access medications, and we have a big research department that are also using research medications. So we were able to get those on site. And then we also needed to look at how we could reduce on-site presence of our staff and visitors to the facility. So this is where we started looking at our family visitor caregiver presence policy. We needed to kind of take a look at what other organizations were doing in the broader community, such as in acute care, long-term care, and other congregate settings. So that's just sort of setting the stage for you. So next slide. So just to give you a little bit of a background around what our visitor policy looked like before the pandemic, I'd like to give you some context. So our previous policy was that we allowed multiple caregivers, siblings, visitors of any age to visit any time of the day up until 11 p.m. So we were quite open and welcoming, but at nighttime after 11 p.m., we had one caregiver that needed to be over the age of 16 that could stay overnight with the child. If we had an outbreak that was just localized to a few clients, then only those clients would have restrictions on their visiting. If the outbreak was more widespread, then all of the clients would have some restrictions limited to 2 visitors on the floor. But our hours and the ages of our visiting for siblings didn't change. Come with the pandemic, we needed to look at sort of what we needed to do next. So in looking at all the guidance documents from Ontario Health on visitor and caregiver restrictions, it specifically said no visitors were allowed in acute care. And it wasn't until later on in the pandemic that guidance came out for rehab and CCC hospitals. So we looked at the guidance documents for visitors in acute care. We did an environmental scan around what our partnering hospitals were doing. And most, because they're acute care, were not having visitors, or at least reducing the access to visitors. And in visitors, we're talking about family caregivers, so that we need to clarify that. We did hear that there were some visitors that were allowed on exceptional circumstances. And some of these exceptional circumstances were related or could be related to our client population. So we felt as an organization, we needed to really make our own decisions based on what would make most sense for us to do. So we felt that we could use our outbreak principles and limit the exposure and potential risk by reducing our caregiver and visitor presence. And so we looked to our pandemic plan. Therefore, we moved to having one caregiver at the bedside and then one other designate that could be rotated out every 24 hours. There wouldn't be an in and out privilege. We also restricted siblings and visitors under the age of 16, so they were not allowed into the facility at all, and especially up on our inpatient units. And we took other IPAC screening measures, IPAC measures like screening, caregiver screening, swabbing, isolation. We would put caregivers and clients in isolation and remove them if there was a negative swab, but we would still monitor them for 14 days. And then later, as the pandemic evolved and we were hearing from our families and the stresses they encountered around this 24-hour hard limit switch out, we did change to allow caregivers to switch out at their own discretion. And then eventually we did add a third delegate caregiver at the bedside. And we'll have a timeline of events that will show you that a little bit later.
As you may remember, the initial guidance document about the visitor restriction was released on March 20th. The document provided details about the number of exceptions, and 3 were meaningful for our context as a pediatric rehabilitation hospital. These were exceptions relating to children, exceptions for persons who are not capable of making their own healthcare decisions, and exceptions for persons who have communication challenges. On this slide, you can observe an annotation that we added to our work, our communications, and our presentations about this topic way back in April, as we recognize how much work has been done over the years, both in creating flexible and welcoming visitor policies and in unpacking the distinction between a visitor and an essential care partner. As a pediatric organization, we have a deep understanding and respect for the vital role that family plays. However, that definition of family comes to be as directed by the client. We know that they are vital to the support and the rehabilitation goals of each and every client that we serve. In 5 days of the new ministry guidance, our working group met to develop equitable criteria and an appeals process while maintaining IPAC measures. Our policy development was grounded in ethical principles, approaches, and interpretation of the ethics framework by the province. It included a co-design process and a multi-stakeholder engagement. It also focused on the language used. For example, instead of the term visitor, family caregiver was used in our communications. And as a design team, we also tackled promotion and socialization of this new policy. Some specific questions the design team asked themselves were, how best could we make clients, families, and staff aware of this new policy? What language ought we to use when we highlight the consideration of client and family-centered care philosophy throughout this policy? Our next steps included communication of the changes broadly to our current inpatient families, our staff, and the community at large through external website. On March 25th, we implemented the COVID-19 Family Caregiver Presence Policy. As mentioned, trust is an essential part of working relationships. Our hope, our aim, was to maintain the trust in our relationships with our stakeholders. For this policy to be successful, 2 of those stakeholder groups that we were most aware of were clients and families and the direct care clinicians who interact with clients day to day. In order to have buy-in for these ever-changing policy, we knew we needed to protect and build that trust. We did this by having a family and youth leader build the policy alongside hospital staff. By using ethical principles to make exception request decisions, and by transparently communicating relevant information about the policy broadly, we were also committed to communicating the reasons or justifications for our decisions specifically back to the individuals that requested exceptions. We recognized how important open, two-way communication would be with this policy. During the spring, we gave tailored presentations to our Family Advisory Committee, our practice groups, and other internal stakeholders. And we have given presentations on this topic as well to our systems partners. We review our Family Caregiver Presence Policy based on predetermined triggers, and information bursts are provided to stakeholders in order to keep open lines of communication when changes are coming or are made. This diagram illustrates the multiple considerations used to develop standard exceptions, deliberate on requests, and also shows information or individuals that could be consulted when we reached our triggers for review. We adopted and adapted the ethical principles in the ministry guidance, resulting in 10 ethical principles to guide and ground our exceptions process. Recognizing the importance of our context, some of the principles guiding us were a direct reflection from our own organizational values, including courage and resilience. We knew that we may have to make difficult decisions in the exceptions process, and we challenged ourselves to use each request as an opportunity to problem solve without compromising our IPAC standards. Kara is going to walk us through what the exceptions process looks like.
Thanks, Dolly. So just to preface this, before we implemented this process, we vetted this all through our pandemic steering committee for approval. So prior to this submission of an exception, our inpatient team and operations managers would discuss the protocol of our caregiver presence policy to all newly admitted and or existing families, answer any questions they had, and provide the rationale for our caregiver presence policy. Many of their questions would often come about, as caregivers would come from other hospitals and experience different family visiting policies. So this slide shows our process for exceptions to our caregiver presence policy. So the family caregiver themselves or staff member on the family's behalf would submit an exception request to our client and families relations team. This request would then be sent to the appropriate manager. The request will be reviewed by the immediate manager for decision-making. If the request was more complex or the family wished to appeal a decision that was previously made, then Dolly, Amon, and myself would discuss it and provide our decision back to the requester. Amon or someone from his team would then communicate the decisions to the senior director of our rehab and complex continuing care team, infection control, quality, safety, and performance, and our vice presidents of programs and services. Then our client and family relations team would document the decision so that we could have a record. This was just in case there was ever a need to provide the evidence or if questions were ever raised around our decision-making. If the request was granted, then this was communicated to our screening team and their name was added to our exceptions list. So this is a bit of a busy slide, and you might not be able to see everything, but this is the form that we created for the staff member or family to submit their exception request. And we had specific questions that helped inform our decision-making. They were around client safety, and if there were any other actions that might have been taken to help the family with their caregiving. For example, providing a paid child and youth worker or personal support worker. So because our caregiver presence policy was at times met with frustration and lots of questions, we developed some examples where families could apply for an exception. So we developed this list of criteria and situations where an exception to the one caregiver presence policy may be granted. So some of the exceptions were related to around safety of the client. So like child protection, parental support due to their own physical limitations, training and skills for potential discharge, the safety of the client or others from harm, like clients that we had that were on one-to-one caregiving due to some behavioral concerns. So apart from the Family Caregiver Presence Policy, we also provided other ways to promote family caregiver visits as the pandemic progressed, and you can see the timeline here. So we offered the loan service of iPads so our clients could have digital visits with their families and siblings and friends. And then in May, with the advantage of having our on-site Bloorview School Authority closed, we were able to use 2 of those rooms so that we could have window visits where the inpatient client was inside and their caregiver and loved ones that were under the age of 16 were, or extended family members were on the outside of the building. In July, as the first wave started ramping down, we moved to using those 2 school classrooms as our indoor visiting. So we allowed 5 visitors or 5 family members, also under the age of 16, to visit with the client. So for a total of 6 for a 50-minute visit, and there was a 10-minute break in between to allow for cleaning and disinfecting. Then as our school started to resume in September, we needed to find a couple of alternate areas. So we had outdoor visits in our gazebo area, and then we provided 2 other alternate locations in our cafeteria level and some meeting rooms in our 0 level. So in October, we also, as the pandemic started to wane a little bit, we increased our family presence in both our ambulatory and research departments. And we also found that there were some real challenges with families who had children under the age of 1 that were breastfeeding. So we allowed that as an exception to be on site. So throughout the whole process, whenever we implemented a change, we would communicate this to our families in a family letter that went out almost weekly, because changes seem to happen so fast. And we were making rounds on the units, so this would help us to gather some feedback and have the families be able to discuss any concerns they had with the changes. We also held family town halls, and these opportunities to touch base with the families gave us tremendous insight into their needs, and we were able to use some of these to tweak our family caregiver presence policy as we moved along in this pandemic. So our policy was very much co-created with our families and caregivers. And you can see sort of some of the changes that we made in the slide.
Thank you, Kara. So now that Dolly and Kara have provided an overview of the exceptions criteria, the submission process, we want to share some really basic data with you. So on the slide, the first 3 sets of columns show you requested and approved exceptions by program area since March 2020 when the process was initially implemented. So the requested being in that kind of yellow, light orange, and then the approved in the darker orange. And that's across the 3 programs that were mentioned. So our inpatient program, our outpatient program, and research institute. We received a total of 129 exception requests across those programs to date and have approved 77. I should point out that for us, the 60% approval rate is actually a relatively positive sign. It suggests that the majority of requests were either aligned to the pre-identified criteria that you've heard of for approved exceptions, or had strong enough reasoning and need for an exception to be made. We can also tell you that very few requests have been outright denied, with the vast majority requiring very careful and critical discussion and follow-up with the teams and families often. Finally, as a bit of an aside, it's also interesting that if we were to redisplay this data as a line graph broken down by month, it would show the highest peak of requests coming towards the end and the beginning of the school year. So June and September months where we received the most requests. Next slide, please. So Kara mentioned this, that it's really important to us that we continuously reflect and work to facilitate client connection to their communities beyond the Family Caregiver Presence Policy. And Kara summarized some of those tactics. A critical way that we've done this is through the creation of indoor and outdoor client visits with family caregivers. So the goal is very simple. Our goal was to design a safe, efficient, and also time-bound way for clients to visit with loved ones from their home community, and particularly those loved ones who may not be designated caregivers or otherwise be able to visit the hospital. The process was also straightforward and designed to be client-driven. So the client family would first start by using an online booking system to select the preferred 50-minute time block that is most convenient for them and the families who'd be visiting between 9 a.m. and 8 p.m. at night. And up to 5 loved ones, not including the client, can attend each visit in a dedicated space that was routinely sanitized and also monitored. Outdoor visits were also possible during warmer months. On the right side there, you'll see a photo of our beautiful spiral garden, an accessible client programming space where we hosted some of these outdoor visits. Next slide, please. Here you can see the tracking of the indoor and outdoor visits over the months. So the total that we've held to date is 340, the majority being indoor visits. The gradual decline that you'll see in the outdoor visits is largely the result of the colder weather and eventual removal of this option in the winter months. The gradual decline that you'll see for the indoor visits correlates to the rise of a second wave and our offering of weekend passes for eligible clients, weekend passes as a short-term opportunity for clients to return home or off-site of the hospital, which was certainly a preferred option to families than these visits. So now we'd like to give you a glimpse of some examples of the types of exception requests that we've received and how we thought through responding to them. I'll hand things over to Dolly.
Thank you, Aman. So as a reminder, our average length of stay is 39 days. However, many of our clients are with us for 3 months or more, which is a long time for anyone to be away from home and family, and especially long for a child. For this example that we have here, we can focus on the principles of equity and safety. So we would like to say that the 2 case examples we're using are an amalgamation of many of the types of conversations and requests, but don't necessarily reflect an individual. So here we have Asaf, who's 12 years old, and he's been at acute care and transitioned to Holland Bloorview for inpatient rehabilitation. The Holland Bloorview context has a majority of shared rooms, either doubles, and we do have a few quads and some single rooms. And so our client Asaf is in a shared room, and his grandmother and mother are listed as his 2 designated caregivers. The client Asaf and his father miss each other as he's been in hospital for quite some time, and the father's work schedule finally allowed for visits from Friday night through to Sunday afternoon. The family decided that they wished for the father to spend the weekends with him during the inpatient stay, and so they made an exception request to be added to the designated caregivers list. As I said, we would be considering equity and safety in this request. The review group would explore if the family had any contextual factors that may impact how they experienced the Family Caregiver Presence Policy. We would ask ourselves questions like, is the burden experienced by Asaf and his family greater than other inpatient families, and in consideration of those personal contextual features, by only having 2 designated caregivers at this time? We would consider safety, and in this case, we would ask ourselves if there was anything about Asaf's family's request that would impact or indicate there was an immediate risk to the client or family member's safety. There were times when we needed to find out more information about the client. In this case, we might ask, does the client need someone at bedside at all times from a safety perspective? Were they in an eyes-on situation or at risk of immediate harm? Were there other considerations like palliative care, end of life, or the receipt of a newly catastrophic diagnosis that needed to be factored into these discussions and decisions? The other thing we would ask is, what about the health of the caregivers at bedside? Did they have any symptoms of COVID? Had they been swabbed? Had they recently traveled? After gaining the relevant information, a clear answer and justification was provided to the requester. This happened in every case. In this particular case study, at the end, the request to have the 3 family caregivers on the designated list was not granted, based on the information and the review from the family and conversation. If we look at another case of Jamie, we can see that she's a toddler and came again to Holland Bloorview to start rehab. Jamie was in a shared room and her parents were listed as her designated caregivers. One parent indicated that they had medical considerations and the family asked for an exception to the Family Caregiver Presence Policy. In this case, both parents and the child were involved in a motor vehicle accident. One of the parents were also injured in the accident, but chose to stay bedside in order to learn Jamie's new care routine and provide comfort. This parent shared with the direct care team that they were finding it difficult to do all of the client's care, especially the physical elements like lifting the client in and out of her stroller and in and out of bed. The parent reported they were extremely tired due to their own recovery and wanted another family member to be at the bedside so that they could rest. After that, they made the request to the process for the 3rd caregiver. Apart from asking all of the similar questions that we did in scenario 1, in order to make this decision, an additional question is the health and safety of the caregiver and their ability to learn the skills needed to take care of their child. Before making this decision or decisions in this category, we also wanted to know if the 3rd caregiver would be at the bedside at the same time as the parent, or if they would be providing respite for the parent and entering into a rotation. Again, the review team used the principles to make a determination. In this case study, we can clearly see how the family is experiencing a greater burden due to the whole family involvement in the accident and the parent's own recovery process. We also acknowledged that while the parent was recovering, some day-to-day parenting activities like the lifting and transferring could not be done safely, putting both the client and the parent at risk if no immediate support was available. After gaining the relevant information, a clear answer and justification was provided to the requester. In this case study, the request to have 3 family caregivers was granted. We've had the opportunity to learn so much about the implementation of the Family Caregiver Presence Policy, and we recognize that there continues to be opportunities to revisit and revise the policy even now.
So obviously there were a lot of ongoing ethical tensions and considerations through the whole thing. And then for an IPAC person, one of the most toughest things that I've had to manage and continue to have to manage is the balancing of IPAC principles and strategies. So the principles that we know to protect clients and staff and families is to limit the amount of people who could potentially bring the virus into the hospital. And limiting visitors also reduces the risk of passing the virus onto them so that they don't also transmit it into the community. And then balancing these measures with the need for families to be physically on site to connect and care with their loved one, with the added challenge of having PPE shortages. So again, we had to determine what made sense for our population, as well as factoring in PPE usage, isolation, swabbing, restrictions of movement within the facility, what was happening in the larger community, and how we communicated all of these decisions to our staff and caregivers. We grappled with a lot of questions such as, can we even isolate a family member? What if the family member becomes sick or has a positive swab? What do we do then? As the pandemic first wave started to wane and community and businesses were opening, the families really put a lot of pressure on us to open and relax our restrictions at the same tempo. There was a sense among our staff that if we opened up too quickly internally, would this put us at risk? And was this a risk that we were willing to take? Some of the things that we learned was that the caregiver presence policy, although protecting clients and families and staff, potentially runs the risk of long-term caregiver mental health burnout. They were telling us they were burnt out. And we did hear of several clients who were struggling with their own mental health, and it was displaying in their physical recovery, as Amanat said earlier. So involving the families and caregivers in the process of determining our caregiver presence policies have really helped us as we've moved along in the pandemic. As the wave 1 started to relax and we started to relax some of our restrictions, we added a third caregiver designate. And we asked ourselves whether or not this was an added risk. We took in account at the time of our local case counts, outbreaks in the region. We were in stage 2 of the city reopening, and then balancing that with the family mental health and our risk and what other partnering organizations were doing. And now, again, as we're in the second wave, we're still struggling with balancing what ramping down should look like with regards to our family visiting policy. But having learned the lessons during the first wave, we've maintained the status quo. We've put in such parameters around our visiting policy that we feel that we're being as safe as we can be if we've gone through the different zones of red and gray and now the lockdown. In fact, right now, we're only just now discussing whether or not we want to ramp down to going back to 2 caregivers from the 3 that we have. We continue to do our surveillance internally and monitoring every change along the way to make sure that we're keeping our clients, staff, and families safe. So a lot of questions that we have for the future are things like, when can we start opening up for extended family members? So when can we bring siblings under the age of 16 to the hospital floor or other areas of the building? Do we or will we have enough PPE? What is the impact on our screeners as more people come into the building? How does adding more people on the units affect our physical distancing, especially in our multi-bed rooms? And then what determines internally and externally our need to ramp up or ramp down? Is it our lived experience? Is it the external context? Is it what's happening within our walls? So some of the key factors that allowed us to find success in our caregiver presence policy was ensuring that all of our decisions were grounded in ethical principles, that we had a clear process for exceptions, all of which were vetted through our pandemic steering committee for checks and balances, and ensuring that we maintained our strong commitment to our client family integrated care. We've learned a lot from how we've worked through our caregiver presence policy, and we certainly haven't gotten it all figured out. And at times we didn't always get it right the first time. We had very, very many iterations, but we hope that we've given you a look at some of the thought processes and decisions that we underwent to get to where we are today. So we want to thank you for taking the time to listen to us. And we are now open to answering any questions that you might have.
Thank you so much for the wonderful presentation, Kara and Dolly and Aman. That was wonderful and very thought-provoking. So please know, everyone who is logged into YouTube, that it's time for questions and discussion via the YouTube chat. So please do feel free to use that chat so that I can receive your question. If you want to send in a question anonymously, then please feel free to send an email to Lori. I believe that she posted her contact information in the chat as well. So we'll give it a moment and let questions start flowing through, or thoughts. Okay. And as we're waiting, are you still able to hear me? Okay, perfect. So just as we're waiting for them to come in, and I'm logging in between different sites, so Lori is copying and pasting the question. So it does take a moment, and there is a little bit of lag time between Zoom and YouTube. So I would love to start the discussion off by just learning a little bit more about some of the perhaps challenges or points of tension that may have occurred when working with some of the family members and just the various interprofessional team members at Holland Bloorview in developing the exception policy. What were some of the primary points of tension? Was there anything that couldn't be adequately addressed from the perspective of family members? It sounds like a wonderful job was done, but would love to learn more about that.
Aman, I'm wondering if you want to answer to start off with. Yeah.
Sure, it's a great question. And I should start by saying that this is kind of like the $1,000,000 question that we continue to navigate day in, day out. So we'll share I might call them kernels of wisdom that we have, but certainly more to come even for us. I would say that you kind of get what you ask for in the world of client family-centered care and partnership. And very early on in the pandemic, we chose to honor our tradition of co-design of client family-centered care, which meant transparency, high visibility, and easy access of families to all of us, from IPAC, infection prevention and control, to my own role in team. Whether it's rounding on the unit, what we call experiential rounding, checking in with families to see how they're experiencing the policy, hosting town halls consistently to get a pulse check. And those conversations often required a lot of emotional fortitude. You have a front row seat to hearing, listening, trying to understand just how much distress in some cases families are in. And what we found ourselves trying to manage was kind of the communications element of that relationship, where in some cases, families were hearing things on the news, they were hearing things from their perspective from the province, kind of publicly, that they were having trouble meshing and aligning to what we were saying our own kind of approach and provincial directive was. So that kind of informational tension, if we can call it that, sometimes created the optics of us not wanting to, as an organization, add as much flexibility and openness to caregiver visitation that families thought we could, even if that wasn't the case in reality. So certainly a kind of ongoing negotiation, and we try to use all of our spaces, town halls included, as Kara mentioned, to really just hash that out, listen and learn, and have that conversation with families.
That's great. Thank you, Aman. And a question from Charlotte is, what ethical principles more specifically were invoked when you were coming up with the guidelines that you did?
Charlotte, thank you for that question. I think that it's a really important one. So as I mentioned, there was ministry guidance that included ethical principles for consideration. And so we adopted and adapted from those, and also really looked to our own organizational mission, vision, and values to inform our policy, because we really wanted to ensure that our mission, vision, and values were represented in all of these difficult decisions that we did. So from a perspective of what's part of our day-to-day values at Holland Bloorview, compassion, courage, and resilience and equity are an example of some of our core values at Holland Bloorview. And then we also recognize that because it's a public health crisis, you're always in these situations considering the balance between individual liberty and also what is necessary for public good. And then the solidarity with the experiences from other organizations, so that families that are utilizing the healthcare system are not having wildly different experiences between where they may be receiving acute care for their children or themselves, and then where they experience their rehabilitation care. And of course, trust was our underlying principle throughout this process. Great question.
Thank you. Okay, anonymous question is, I hear a lot about pandemic caregiver burnout. I hear a lot about pandemic caregivers burnout, that staff fear of the virus, but they haven't heard anything about child development and trauma due to separation, and also the trauma of illness. And then I guess adding that, namely the illness, to that separation from family and friends, altered body image, concerned about a lack of regard for the meaning of this separation. So for example, in the one case where the father was not allowed in. So it seems as though this person is really looking to find more information about how these moments of separation, or these long moments of separation, might actually influence childhood development and trauma that is experienced in relation to that case specifically.
Sure. I mean, it's a great comment. I might take a stab into. I can't think of research or resources off the top of my head, unfortunately. I would encourage you to contact us. I believe our emails were showed earlier. We can certainly have that conversation and share what we can find. I think to the point of the comment, it's why, we try to use these conversations with families as educational moments as well. So when a decision was being rendered, if I or a member of my team was reaching out to a family, unfortunately, if the answer was, let's say, a denied request, we really spent time patiently explaining our principles, patiently explaining our grounding and why we were unfortunately unable to grant the request. So really staying again present in the conversation. So it wasn't just a no, but it was a no with an explanation and kind of an ongoing relationship. Hopefully that would be built from there. But it's a great comment and important to highlight. I'm glad they did. Thank you.
And I think really it also speaks to the fact that with the experiential rounding, we had a real opportunity to hear feedback, not only in that moment when decisions were delivered, but also throughout. There was experiential rounding and also family town halls. And so there was opportunities for families to participate in voicing questions in the moment and feedback. And I think that's why we really felt it was important for this presentation to include some of the other activities we did to balance family caregiver presence in the hospital, including the indoor-outdoor visits. So starting with window visits, which many hospitals had that opportunity and tested it out, but also having indoor and outdoor visits, because we recognize that kids that have siblings are used to seeing their siblings and have, sometimes very close relationships. And it's funny, I would never think that I would need to read a research article about this one statement, but I read it recently and it was very powerful. And it said, the longest relationship you're likely to have is with a sibling. And, when you think about it, it's true. They're the person that you've, if you're the bigger one, the person you've seen growing up. And if you're the little one, it's the one you've looked up to your entire life. And so really trying to put into context opportunities for families to be able to spend time together in ways that were meaningful. And I also will say that although virtual may not work for everyone, we really tried our best with having almost an iPad for every single, at the time in the spring, we had an iPad available to every single client that was an inpatient so that they could borrow and didn't need to be reliant on their own personal access to a device in order to connect with clients and families.
Thank you for that. And I think that Kara also wrote in the chat that in the Zoom chat that they also strategize with other methods and ways that the father and child could interact. Just want to mention that since on YouTube, it probably didn't transfer over at this point. Just looking at the time, it does seem as though we are running very short. So it is time to draw today's seminar to a close. It sounds as though the presenters are open to receiving additional questions or connecting. So perhaps that is something that could be considered if you have a question that you'd like to ask. I do have a couple of announcements to make before we thank our speakers. So our next seminar will be on Wednesday, January 27th, where Jeff Nisker will be discussing what's in a name, names confusing decision-making in reproductive genetics. So to sign up to receive our weekly seminar reminder emails, please email jcb.info@utoronto.ca. CSB students who are enrolled in the CSB Student Seminar course, please do remember to keep track of your attendance. And Dolly, Aman, and Kara, just on behalf of all of us, thank you very much for a thought-provoking and insightful presentation. We appreciate it.
Thank you.
Yes, thanks for having us.